Welcome back to BRUIN BANTER.
All right.
Alright, today we are doing
A
crash course of clinicals.
Yes.
A CCC, if you will.
Of course. It's daytime. We planned for this podcast. We have ideas of what we're going to say.
Yeah, this is crazy.
It's looking up. I think that this is good. Yeah.
I agree. This is pretty good.
So the idea here is that we wanted to talk about clinicals, since that's obviously something we haven't touched on at all during this podcast. And we kind of looked around on the internet, and there wasn't really much about general advice like from nursing students for nursing students. And I know the biggest thing, I was probably most stressed for clinicals out of like the majority of things in nursing school. It was just the most like unsure. We had no idea what we were walking into, and I think something like this would have been super helpful. And I know I've touched on this a little bit on my channel, but I think we're just going to go into more detail about specific aspects of clinicals, and hopefully it'll be relatively helpful.
Yeah, we're just looking to kind of inform any either current nursing students, any prospective nursing students, kind of like an inside look. And of course, this is unique to our experience that we've had. We're with UCLA School of Nursing. And so
In the bachelor's program.
There's two programs. There's the BSN, which is the bachelor's, and then the MECN program, which is the master's in entry-level nursing. We're with the bachelor's, as Lisa said. So a lot of this experience that we're talking about, it may or may not be shared with other nursing schools. So don't take everything that we say, like this is our little disclaimer, don't take everything that we say as like absolute or universal for every nursing program, although some of them are very similar. This is kind of more our experience, but we hope that it'll be helpful.
I think some of it will definitely be pretty universal. So all right,
let's get started.
Let's get started. Let's see. First thing, I think I'm just gonna pick a topic. I think that something that we were talking to our other friends about yesterday in the past few days was the concept of, obviously as a nursing student you do a lot of advocating for your patients,
Absolutely.
but something that not a lot of people talk about is the idea of advocating for yourself as a nursing student. I think that's a good place to start.
Yeah, you're right. And we'll touch on like advocacy in general in the hospital setting as we get more into it, but I agree. I think it's good to start with advocating for yourself.
Yeah, I think also, especially during your first clinicals, this is something that's really important to have like from the get-go, whether you're encountering like a preceptor who's maybe not treating you the way they're supposed to, a patient who's not treating you the way they're supposed to, a clinical instructor. You need to know where the professional boundaries are and how to actually address those and make sure that you're receiving adequate treatment.
Yeah, I think it's also important to remember that you will be doing your clinicals at somewhere that's not a teaching hospital. The whole point of what's called a teaching hospital is that is a hospital that specializes in teaching students about medical care. And whether that's nursing students, whether that's med students, or really any of the fields that are in the hospital. If you're a student, they're supposed to help teach you. So with that being said, one of my professors told me like the most important thing to remember is that just because you're a student, you're still part of the healthcare team. So you still have a role in that team regardless of your student status. You're still important to patient care. So it's just important to remember that when you're going in. Of course, be humble, understand that you have a lot to learn, but with that being said, your opinions and your patient concerns shouldn't be discarded just because you're a student.
Yeah, I mean, it really is that like nurses and CNAs and everyone within that unit is relying on you. Like there are duties that you were assigned to that you're expected to follow. So it's not just that you're on a field trip and you're just learning about different patients. Like especially as you get further into your clinicals, you really have responsibilities. So that's a really good point. Yeah.
I think that like one thing that I've learned too is that you have to be vocal about either what you want to do, about what you're able to do. If you just show up to part of the self-advocacy is, yes, you have to talk, but you also have to like walk the talk, basically.
Yeah,
like you have to, of course, you have to be able to advocate for yourself, but you also need to have your actions match what you're saying. So if you're saying, oh, I can do this and this and this and this, and then your nurse is telling you all the stuff that needs to be done with your patients, you want to make sure that you're then asking, oh, can I do this? Oh, would it be okay if I do this? Or, oh, I know how to do this, I'd love to. And if you just stay silent, you're not going to get any opportunities, really, I feel like. I mean, you'll get some, but you won't get as many.
Definitely. Yeah, I think a part of that, one good thing that our program taught us, this, I remember this even just in our very first clinical orientation before we ever stepped foot in the hospital, they gave us like sentence starters for when, do you remember this, when we introduced ourselves to the nurses? They were like, this is what you're gonna say to your nurse when you meet them. And I remember like the most nerve-wracking thing first day of clinical was even just finding your nurse. Yeah. They were like, oh, this is your nurse's name, like go around and ask like where this nurse is. And it's like, it just feels so uncomfortable because you're like, these are such professionals and you already feel like you don't know anything. And then, it's just... Yeah,
you're so right. That's a good point.
So what we were taught is you go up to the nurse, you say, hi, my name's blank. I'm a nursing student with UCLA or whatever school. In our case, we would say, oh, this is our very first clinical. We've never been in the hospital setting, but we've had experience in like the lab setting with mannequins and all of that. And most importantly, we are able to, let's say at this point, we were able to pass oral meds and we were able to do assessments and vitals, but we were not able to do IV meds. So things like that are really important. That's really what they're looking for. You think of the things that nursing students would be expected to do in the hospital and you make sure that they know which ones you can and can't do based on your skill level.
And it's also, it also really depends on how that floor that you're doing your clinicals with does their huddle. Because sometimes in our experience, and Lisa and I have been in different clinical groups since we've started. So we both have, but we've been at the kind of the same hospitals.
Same places,
different groups.
Yeah, different professors.
But it really depends on the culture of that floor. So some floors do huddle in the morning all together in like a big hallway, and your nursing professor might be like, oh, we have students here with us today, they can do this, and this. Please let them do this, and this. Or I've had professors be like, oh, Taylor, can you please introduce the students to the floor? And then it's my job to say, hi, we're blank ear nursing students. This is our first rotation. We're able to do this, and this, but we have to do this with supervision. Otherwise, and you might have stuff to add to this as well, if you have like a day shift for your clinical, they move really fast in the morning at the change of shift.
The first like 2 hours are nonstop.
Yeah, so you don't really, like in my experience, you don't really have time to like sit down and like talk with the nurse about, oh, like my name is this and we have this and this and this. It's like on the go. So you gotta find your nurse and like you tell her. So like usually I'll try to find my nurse and basically, like, when they come out of the huddle or when they're in huddle, you start, like, looking at their name tags. Usually you'll know who they are.
They're not looking for you.
No, they don't know what student they have, but you know what nurse you have. So you have to be really vigilant, and don't be scared to ask. Don't be scared to be like, oh, do you have, I'll just say, like, I'll use my name. Let's say my nurse's name was Taylor. And you're like, oh, do you know who, or would you mind pointing me to where Taylor is? You can ask other nurses that, and they might be like, oh, I'm Taylor. And you're like, oh, thank you so much. Great. I'm your student for today. If they're busy and if they're doing handoff for the day, which is where the night shift nurse is kind of giving, which is something we'll get into later, called SBAR. The night shift nurse is giving something called SBAR, so the day shift nurse understands what's going on with the patient. You wait. You don't want to interrupt the SBAR to introduce yourself. So usually what I'll do is I'll walk with my nurse. Like once I find them, I'll walk with them and kind of give my like very quick spiel. Hi, my name is Taylor. I'm a nursing student. For my first clinical, it was, hi, my name is Taylor. I'm a nursing student. I'm a third year. This is my first clinical. I can do basically anything except pass meds without supervision. And I can administer all meds except for blah, 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 blah. Hi, Simon. Simon wants to get in on the... anyways, I'll keep going.
Yeah, go ahead. Actually, I have one thing to add real quick.
Yeah.
I have one more tidbit in terms of finding your nurse, because like I said, I do think that was really stressful. What I started doing towards my later clinicals, if I couldn't find my nurse during the initial huddle when all the nurses were there, I would just go to my patient's room.
Yes.
Because most of your, if you have like if your nurse has 3 or 4 patients and you're lucky enough to know all the room numbers already before you meet your nurse, then you can just stay around those rooms, and inevitably that's where your nurse is going to go, because they're going to do their handoff or their SBAR either in the patient's room or at the nurse's station closest to it. So that's always a good tip, is if you don't know where to go there and go towards your patients.
Yeah, I remember my first clinical, I was really, really scared about going into my patient's room without my nurse, or if I didn't know my nurse was in there. But the most important thing is to be kind of confident with the way that you're delivering your care. So I was so scared. I would not go into the patient's room until I had met my nurse, because I was like, oh my God, what if they ask me questions I can't answer? Or what if I interrupt my nurse like during handoff? But the best solution, as Lisa said, you can wait by your patient's room, or you just knock. You just knock and you peek your head in, and if the nurse isn't there and you're like, oh my gosh, what do I do? There's a patient there, you just introduce yourself. You just say, hi, my name is blah, blah, blah. I'm the nursing student. I'm going to be helping with your care today. Great. And that's it.
Yeah.
And if your nurse is in there, you knock, you open the door, you look, you see that the nurse is in there, you close the door. If they're in the middle of handoff, you just wait. You just stand there. They know that you're a student. Again, this will be at a teaching hospital, so they are familiar with students.
You're allowed to be there.
You're allowed to be there.
You're not taking up space.
Yeah.
Yeah, and then, I don't know, in terms of other things, I think that's just a really good thing to keep in mind, is that you're supposed to be there. Like, even if you don't feel like you know what you're doing or you know where to be, there's not like a right place to be. Like, no one's going to judge you for standing in a weird place or anything like that.
Yeah.
Just don't get in the way of things. Or like, if there's, let's say there's like a code and you go and want to observe the code, like, be mindful of where you are. Don't, if there's any kind of big emergency things, be mindful of where you are, be mindful of what you're doing. And if someone asks you to help, be prepared to help in any situation. I don't know. The hospital works very much as a team, like, especially within the nurses. So it might be like another nurse might ask you for help, a nurse without a student, or a nurse whose student is busy doing something else. So just be prepared to help in any way you can, and that will really make you look good.
Be like, advocate for yourself. If, for example, you got cleared to pass medication, and if you always have to do this with the supervision of a licensed nurse, you can never pass meds by yourself, which you'll be told, but just so you know. But if you're cleared to pass medications with your nurse without your instructor present, make sure your nurse knows that. And if your nurse is getting ready to give the patient the medications and you don't have any experience with that, just ask. Just say, hey, I got cleared to pass my medications. Would you mind if I help you give them to this patient? Or if the nurse has to check blood sugars, or if they have to collect like intake and output, just ask. The worst thing that will happen is the nurse says no. And then you're just like, oh.
Which doesn't really happen. They're usually happy to give you the tasks that they do a million times a day anyway.
But they won't always, your nurse will not always offer it to you unless you ask. I've had some nurses ask me directly, would you like to do this? Would you like to do this? You always say yes. Always, always, always say yes. If you don't know how to do something, don't say no. Just say, oh, I don't know how to do this, but I'd love to learn. Always be ready to learn. I've said that a few times. A nurse asked me to empty a JP drain, which is a special type of wound drain, and I didn't know how to empty those because it was my second clinical. But I didn't say no. I was just like, I actually don't know how to do that, but if you show me, I can do it for the rest of the shift.
And I think that also applies. I think a lot of people are hesitant to do the kind of bigger skills if it comes to like inserting an IV or like inserting a Foley catheter. Once you're cleared to do those things, it's like you're not going to be any more prepared. At any point, you're going to have to do it inevitably, and it's better to do it. Honestly, it's better to do it in the clinical setting.
I agree.
When it's not on your license. Like, as horrible as that sounds, it is true that you have more support and more people around you that are able to guide you and tell you what to do, as opposed to if you wait until you're an actual nurse, and then not only do you have less people helping you and letting you do it at a slower pace, but also they're expecting higher levels of work from you. So it doesn't look great on you if you don't know how to do those skills yet. You know what I mean?
And again, some of those opportunities, you're going to have to ask for them. So you just have to get kind of comfortable understanding that you are able to do those skills. You just have to ask sometimes. I've done 2 Foley catheters now, and both of those times, one time I asked, and another time I was asked.
Yeah, same. That was exactly,
yeah. And so the first time I was like, oh my gosh, this is my chance.
And it
it's
takes
happening
some
on my
nerves.
patient, and I was really scared because I had only ever done it in a clinical setting, and for that lab
setting.
I had in a lab setting, but for that lab I had been injured, so I had to do a makeup lab. I didn't even get the full lab, so
Yeah.
I was quaking in my boots. But I asked my professor if she would support me in that and if she would be willing to watch, and she was. And I had you have so much more help than you realize. I had my professor helping me, I had my nurse helping me. And was it scary? Yes, it was very scary. But I had help, and that helped me feel more confident and able to do it, so that the second time when I'd had more experience and a patient needed a Foley catheter, the nurse asked me if I wanted to do it, and I said yes.
Yeah, once you've done it once, you really do feel like
Yeah.
so much more confident in the skill.
Yeah.
The other thing I was gonna say is also, as you especially like within the same shift, if you start volunteering for more things, more opportunities will come to you. Like there was one shift where I was just like volunteering for more and more things. I was doing all of the blood sugar checks. We had like 3 patients on acu checks or blood sugar monitoring, and my nurse could tell that I was really independent with those things, and so she had asked me, there was specialty nurses coming in to take care of this wound with a wound vac, and I was asked if I wanted to just observe that procedure. So it's not that they're getting anything out of me by asking me to do that, but they're allowing me to see this other procedure because they can tell that I'm very passionate and very motivated to seek out those opportunities, and so they're keeping that in mind and finding more opportunities for me to participate in. And so it's even like watching procedures, going into like scans and other procedures, like you'd be surprised by how much you're actually allowed to do.
Yeah, and I think like Lisa was saying, it's a combination, and what we were saying before, it's a combination. You have to verbalize, but you also have to practice what you preach. And you have to, there's one thing to tell someone that you can do a bunch of things and then sit at the computer all day, and another thing to tell your nurse that you can do a bunch of things and then actively ask or just actively do those things. Probably the worst thing that you could do would just be sitting at the computer all day and not doing any skills, because just like any person in real life, it's really important to establish good rapport with your nurses, and that's how they trust you. If you establish a good rapport, if you explain to them what you know how to do, if you show them what you know how to do, and you also are not afraid to ask them questions, they'll trust you. And like Lisa was saying, the more that you show, the more opportunities will come your way. And with that being said, it's also important to remember that when you're in the hospital setting, these are real people that are your patients. They're not mannequins. It's not a case study. These are real people that are sick and they are not feeling well, and they're in the hospital for a reason, and they would have anywhere else in the world that they would rather be than the hospital. So if something cool is happening, if a new skill is being shown, you also want to remember that yes, while it's exciting and interesting and cool to see something done that you've never seen before, remember that it's still happening to a real person. So you want to be cognizant of the language that you use in the hospital and just the general attitude that you have towards things that are happening. Taking vitals is not a menial task. That's important. If you get, I just took vitals, I just checked blood sugar, those are all important to the patient's care. That's how you monitor their condition. So take everything that you get with humility and grace, and just remember that these are real life people that you're helping. So for inserting a Foley, you might be like, oh my god, that's so cool, but it wasn't cool for the patient.
That's a super invasive device.
It was not
painful.
cool for the patient. And so just keep that in mind. I feel like, and I say this because in my first clinicals, I was really focused on I'm doing all these skills and that's really cool. It's very easy to lose the fact that these are not very easy, but you can forget that these are real people. So patient communication and patient rapport is just as important as rapport with your nurses.
Yeah, I agree. Okay, that feels like sufficient for that topic. Time for the next topic.
Okay. So we mentioned earlier something called Handoff, which happens in the morning and in the night with change of shift. But probably the pinnacle of handoff is something called SBAR. This is a type of report that really anybody on the care team is responsible for giving kind of at any given point.
For sure, yeah.
For your patient. And it has a multi-purpose. In handoff, the biggest purpose is giving the oncoming nurse, so the night shift nurse is going home, the day shift nurse is coming onto the shift, but before the night shift nurse can leave, they have to give report about what's going on with their patient, anything important that you need to know, and kind of goals of care. And do you want to go into what SBAR stands for?
Sure, yeah. So SBAR, this is what we were taught, and I think it can be a little bit different. Some people call it like the BRUIN, and so there's a few different terms, but SBAR is the general idea for kind of the outline of it. So it goes in order. So it starts with situation. This is your basic like 3-sentence thing about who the patient is, what their situation is, why they're here. Like that's their situation. Background, B is for background.
Yeah, I was gonna say, and for situation, that's just the stuff like patient name, age, date of birth, allergies, like very basic, like need to know stuff.
Yeah, exactly. And background is then going more into their medical history. So that's going to be if they have any previous health concerns, I put allergies in background, but I guess that could go in situation too.
I guess it could go in background too.
Yeah, and then it's in general just like medical, psych history, anything like that. Surgical history, yeah.
And that's like, sometimes it can also be like a little tricky because background, sorry, I'm gonna interject.
No,
in situation, you have like, they were admitted for this, but background can be they were admitted for this, which was caused by this, which is an exacerbation of this. So it's more, you can still have the background of the current medical diagnosis as well as past medical history.
Yeah, that's a good point. Yeah, so that's background, and then the next big thing is assessment. So a good nursing assessment is kind of the foundation to getting to know your patient. You know their background, you know their situation, you know who they are, but you don't know what's actually going on with them right now. So an assessment is going to be a head-to-toe assessment, looking at all of their vital systems and really getting an idea of where they're at right now, like what their condition is at. And so with assessment, you would be going over, like I said, the head-to-toe assessment that's in the chart, and just usually when you give assessment in report, you're going to just give the abnormal findings. So maybe like they have stomach pain, and you would go into that and say, oh, they have 8 out of 10 pain, we're treating it with this medication and all of that. So, or like they're neurologically impaired, things like that, that would be important to mention that are different from the normal findings.
I think it's also important, and we'll, after we explain like what the acronym is, we'll get into how to give a good SBAR. And the BRAIN and SBAR are kind of intertwined in that your SBAR is like a full rundown on the patient, and the BRAIN is your plan of care based on the SBAR. So your BRAIN can include the most important like connection between the BRAIN and SBAR is the assessment that you're doing, because that's going to determine the plan of care. So a good assessment is so crucial. And it's like Lisa was saying, it's important to list the problems or like the abnormal findings, but it's also sometimes can be good to list relevant normal findings. So for example, if a patient was admitted for like respiratory failure, and they're really swollen, but they have a regular respiratory rate and their oxygen saturation is good, even though those are normal findings, it's good to mention because that's relevant to the diagnosis.
Yeah, definitely.
So any abnormal findings as well as any findings relevant to the diagnosis. If they have lung failure and they have full range of motion of like their legs and full muscle strength on their legs and they can walk around, you can summarize that really quickly. It's something called a BMAT, which just determines how well a patient's able to ambulate. You don't need to go into like, and they have full range of motion on their left leg and full range of motion on their right leg,
and they walk this on this far,
and this far, blah blah blah. That's not the primary they're not diagnosed with a fracture, and they're not diagnosed with weakness, and because that's all normal, you can just say normal range of motion, BMAT4, which is something you'll learn a little bit later. But
Sure.
the importance of SBAR is to be concise.
Yeah, and this kind of goes back to what we were saying earlier. With SBAR, when you're receiving handoff from the nurse, the reason why this needs to be so rushed is because you have a lot of things to do. You're getting to let's say you get to your unit at 7. Let's say
6:30 or 7.
Let's say your shift starts at 7, right? So you get there, you're already going into your shift. Like this is taking time off of your shift, meaning that you probably have medication due at 8, you might have medication due at 7. So you already feel like you're behind. You have 3 to 4 patients that all have medications due at the same time. You have to do all of their assessments, ideally before you're giving the medication.
Yeah.
You have to do vitals, you have to do probably blood sugar checks, all of that within the first hour or two. And so you don't have time to listen to this entire patient's history. You're not going to be talking about how their grandma had a birthday yesterday and how they this and this and this, right? You're not going into the details of their actual lives. You can find that out later, and unless it's crucial to their plan of care, it's not necessarily relevant. You'll see it in the chart, and you can dive into that later, but it's not something that needs to be reported right away.
Yeah, and I think it's good to have certain pertinent medical information in your head or at least on your sheet, but you don't always need to give it in report. And that leads us to the last letter.
Oh yeah.
Of SBAR.
R.
R.
Do you want to do it? Okay, so R is for recommendation. So here at this point, right, we have a situation, we know what happened to the patient, we have a background of their medical history, their family history, all of that, if necessary, if related, and then a full assessment of how they're doing right now. So recommendation is what the off-going nurse is telling the new nurse to do. It's her recommendation of what the plan of care should be and what any pertinent things that are upcoming too. So let's say the patient has a procedure scheduled for 11 a.m. and they're on a 24-hour NPO order, meaning they're not allowed to eat anything. So that's super pertinent to know so that you know if you're the off-going nurse and you don't tell them that they have a procedure at that time, especially if it's in the morning, they're not going to be prepared to have the patient go to the restroom and get ready and sign the right forms and all of that.
Yeah.
So any things that are urgent like that are super important to mention in recommendation. Also, if they need any kind of consults to any specialists, that would be important to mention there. When they're getting discharged, what the plan for discharge is, what the goals are as we're approaching discharge, things like that.
Yeah, the most important thing, and the reason that the first 2 hours are so hectic is because you have to prioritize the level of care, the order of care that you're giving, which is why recommendation is really important.
Yeah.
As well as assessment, because you might have been planning to do one thing and you're like, oh, actually, this patient is pretty stable, and the doctor's note says that they don't need this if their vital signs are this and this and this.
Yeah.
So you change the way that you're going to order your care and the priority of care.
Yeah.
But yeah, it's really important. It's a very overall view of the patient. And again, you're not going to give what you might write down. You're not gonna, or the entire patient's medical history. You're not going to go super into detail about that, but you should know it in case you get asked. I've had situations where I'm giving SBAR either to my nurse or to my professor, and they ask me, oh, well, what did this lab level look like? And even if that wasn't in my SBAR, I still should know it because it's important to the patient care.
Right.
So any quote unquote relevant data or assessment data to the patient's condition or current condition, because sometimes a patient was admitted for one thing and that was the priority when they were admitted, but then now that they've been some patients are at the hospital for a few days, some are there for a few weeks, and some are for a few months. If they've been there a long time, their goals of care may shift. They might have been admitted for one thing, but now they have something else that's more important, that the other thing has been resolved. So it's important for you to know that as well.
Yeah, and I think also that an ideal SBAR will be concise but also thorough. So you want you want it to be brief and concise, but you want it to be thorough in that it's giving you a thorough view of who this patient is. You want to know and be able to visualize the patient before you're going into the room.
Yeah.
And then, so like Taylor was saying, people will oftentimes, actually almost every time, ask at least some questions about the patient. And so you're giving them the key information, expecting questions, and that's because they're also writing down, right? So The idea with an SBAR, you have your BRUIN or your sheet, and this looks different for every single nurse. Some hospitals require you to use the one from the hospital. Some hospitals let you use your own.
Some people in my cohort use just a blank sheet of paper because that's easier for them to organize. But we can have some examples of. But yeah, so the form is different.
Yeah.
As long as you know where to write stuff down, doesn't matter.
Yeah, you'll probably be given some by your program. I encourage you to make your own. The one that I threw up was mine. So I really, really like mine. I'm very proud of it. I've worked very hard on it. And it's really just what works best for you. And you're going to be writing faster than you've ever written before. So you want to write down as much as you can, as efficiently as you can, in a way that you'll be able to reference it again later and add to it.
Yeah.
So yeah, get creative with it.
Yeah.
Figure out what works for you.
And that's why, like, this is kind of a side note, and this is like by choice. Like, this is not mandatory. This is just my little like nugget of advice. I like using, or most nurses use, like those pens with like 4 different colors on them, specifically for their SBAR. Because what I've seen nurses do, and a behavior that I adopted because it makes so much sense, is they'll write all the basic stuff like in black ink, let's say. Any new data or anything new that just happened in the last shift, they'll write in a different color, so like red or green. Anything important, they'll write in a different color from that. And that's again because you just have this paper. You're not able to sit at the computer the entire time, and you shouldn't really. So if you pull out that paper, you want to be able to look at it and know, okay, what's important, what's pertinent. A lot of nurses too will write like squares next to things that need to be assessed or need to be done throughout the day so that they can manually like check it off when they're done. And I found that really helpful to do as well.
Yeah.
But just to give you like kind of a bringing it back to SBAR, it seems impossible. It seems like you're like, how can I give the entire history of this patient in less than 5 minutes in the morning, if even, and how can I hear all of this from the other nurse in the morning and write it down and remember it all? It comes with practice. It's not going to be perfect the first time you try it, and that's okay. You're learning. It's important to remember that it takes practice. It's going to come. It might feel impossible at first. It might feel like you're lost and everything's moving really fast.
And there will be so many acronyms you don't know.
When Lisa was explaining kind of the schedule of the morning and how everything happens in those 2 hours, it's true. And at first, it can be a little overwhelming.
Definitely.
I was overwhelmed my first clinical. I think it definitely takes time and practice. I feel like knowing what to expect helps a lot.
Yeah.
Knowing what you're in for helps you prepare better. I think a good SBAR sheet is a lifesaver. Depending on the hospital, usually the hospital will give the nurses the template, and you can ask for that. Because another thing I've noticed, and I don't remember if you mentioned this already, so I'm sorry. The nurses will give SBAR based on that floor's blank SBAR template.
Yeah, it's true. I've noticed that too.
And so sometimes SBAR sheets have like the assessment in different orders. It'll be in different spots on the page. Again, like Lisa said, every hospital and every floor is different. Every person. At least at the units I've been on, the entire unit will have an established sheet. And it's different between units, but the entire unit will use the same one. So I'll ask for a copy, and I'll make photocopies of it, or I'll ask for 2 copies. That way, when the night shift nurse is giving their SBAR on what happened with the patient the night before, I can follow along in the order that SBAR is being delivered in.
Otherwise, you're jumping around on your page, and you're like, wait, what?
You're like, wait, they did cardio first, and I have neuro first, and all this stuff. So it helps.
That's a great point.
I think having, like, again, and that ties back into our earlier point of don't be afraid to ask. Don't be afraid to ask for things that you need. I feel like there's a difference between being unprepared and asking for things. Don't think that just because you're asking for something that you're unprepared. They're very different. Unprepared would be like you don't have a pen. Your nurse asks you, oh, can you give me this? And you're like, I don't have it. And then
the
best thing you can do, this is like another like gold star tip, and maybe this fits in later in the video, I don't know. the best thing you can do is be prepared with stuff.
Yeah.
Like, yes, be prepared with knowledge, but be prepared with physical stuff.
Yeah.
Have your pens, have your Sharpies.
Scissors.
You will need it. Have scissors. The nurses a lot of times
Don't have scissors.
don't have scissors.
And then they ask you,
And they
assuming
ask
they go
you.
have them.
And if you don't have them, this is what I've noticed. If your nurse asks you for something and you say you don't have it, they will not ask you for something again.
Mm-hmm.
Yeah.
Okay. So yeah, one more thing that I think is also super important is when, like we said, being prepared with supplies. If you can,
Yes,
depending.
supplies is a better word than stuff.
Yeah.
Sorry.
Depending on hospital policy, it's kind of depends on the hospital as to whether or not this is what they like to do. But at some hospitals, a lot of nurses will gather alcohol swabs and saline flushes for IVs and tape and gauze and all of those kinds of things.
And these some hospitals have these like green caps, like IV port covers.
Mm-hmm.
You will see like your nurse, the very first one, they're usually, sometimes they're in the medication room, sometimes they're in the utility closet.
Mm-hmm.
But if you're following your nurse, the first thing that your nurse, like, guarantee, I have never had a nurse not do this. The first thing that they're going to do is when they go into that medication room, they are going to stock up on supplies, and you better do the same thing.
Yep. I've had nurses say, like, no nurse is a good nurse unless they're carrying, like, alcohol, or they're like, a nurse is not a nurse without alcohol swabs, or, like, things like that. Like, they really rely on these things, and it makes sense. It's really a very important thing to
You
have.
will be shocked by how often you will use those things.
Yeah.
I would say the other big one, too, like we were saying before, scissors and tape.
And we have tape. We have tape in our lab pack, so I think most of us just brought our own tape.
Yeah.
A lot of the time, but there's also tape in the hospital.
Yeah.
It's super important.
Yeah.
Gloves.
Good to be prepared.
The gloves on the wall.
And again, if your nurse asks you for something and you don't have it, they may not ask you for something again, which is not good. Because then they don't think that you're prepared, and then they're like not gonna ask you for stuff, and then they're not gonna get it. Like, it's the smallest stuff like that. Like, if you want to be proactive, like, just be prepared with supplies.
Yeah,
it may seem like kind of simple, but
it makes a huge difference.
it makes a very big difference.
Mm-hmm. It makes you look good. It makes your school look good too.
Yeah, and it's hard because when you're in clinical, it's a teaching hospital, but you have to remember that teaching someone takes time. Now the nurse is having to do their own job of taking care of the patients, and then they're also having to take the time to teach you how to do it. Yeah. And if it's a really busy day, they're not going to have as much time to, like, explain every single thing or, like, sit down and have a conversation with you. So it's just important that you're prepared and you're just presenting yourself ready to go.
Yeah, I agree.
And if there's something you don't know, there's no shame in that. Ask.
Yeah.
Or look it up on, like,
it won't make you look
websites.
Bad.
No, it actually makes you look worse if you don't tell them that you know something, and the time comes for you're supposed to be able to demonstrate that knowledge and you don't know it. Right. Especially because, again, you are dealing with the care of real life people.
Yeah, that's unsafe practice.
That is very unsafe.
Yeah.
If you don't know something but you're acting like you do.
Yeah.
Remember, like, it's this interesting balance between you want to be confident but you don't want to be arrogant.
Yeah.
You want to be confident, you want to put your best foot forward, you want to be vocal and advocate for yourself, but also stay humble.
Mm-hmm.
Know
what questions to
know
ask.
what questions to ask.
Feel comfortable asking those questions.
Yes, that's what the confidence comes more in, being comfortable in the hospital setting, being comfortable asking questions, being confident introducing yourself to your patients,
knowing your role in the
hospital. Totally. Like, for medications, don't volunteer to administer medications before you know what the medications are. Like, you can volunteer and say, can I give these medications? And if your nurse says yes, then you say, great, I need to look up what some of these are. Right. Unless you can, or can you tell me what some of these are? Yeah. Because patients will ask. I've had patients ask me, what does this medication do?
Yeah.
Oh, what does this medication do?
Oh, what does that mean?
Oh, wait, what
can you elaborate on that?
And if you don't know, that is unsafe.
Because then what's the patient going to think if you're giving them this pill and you don't even know what it is?
Yeah, it's not safe.
Not at all. Okay. I think we'll kind of move on from here. Simon.
No. Simon
So.
wants to speak.
Our last and final topic for this video, I feel like we've been talking forever, is Simon's joining us for this one, is going to be care plans. Dun, dun, dun.
So, disclaimer, real quick. And it will be a quick one, but I'm making it longer now.
Go ahead.
Not every school is going to have the same paperwork. UCLA, every school is going to have different requirements for your clinical assignments and your paperwork. Some schools have very, 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 very detailed paperwork that you have to do. Other schools don't. So this is going to be a little bit more unique to schools, but in general, the one thing that they do have in common is a care plan.
Yeah, and our care plans, we've been told that they're kind of outdated. Have you heard that? That since
they don't use care plans in the clinical setting anymore.
Well, yes and no. Thing. Yes, I would disagree. Actually,
but the way that they don't use. Sorry, let me clarify. They don't use nursing diagnoses anymore.
Yes, and our care plans are kind of centered around these nursing diagnoses, and we'll get a little bit more into what that actually means. But other schools and probably eventually our school are moving more towards the clinical judgment model, which is what is more close to what's being used in the clinical setting. But we still use nursing diagnoses, so that's what we're going to talk about.
Yes.
Because that's what we have experience with care plans.
Yes.
So nursing diagnoses. There's two different diagnoses in the nursing world. There's a medical diagnosis and nursing diagnosis. And so your medical diagnosis is going to be the pathophysiological thing that's wrong with you. So
for example, I was just on the liver floor, so I'll use that as an example.
Great.
Someone's medical diagnosis would be cirrhosis or liver disease, liver injury, liver failure, usually just cirrhosis. Continue. Or do you want me to continue?
Well, okay. Yeah, so then related nursing,
I was saying cirrhosis.
Oh, okay. So nursing diagnoses with that, we usually come up with 3 or 4. So in our care plan, we'll have like an SBAR with the patient's actual medical diagnosis, and then our nursing diagnoses will be centered around the care that we provided to that patient. Yeah. So let's say the patient has liver cirrhosis. So one of their nursing diagnoses, I'm going to take a cop-out one here, might be acute pain.
Yeah, so the medical diagnosis is like actually the pathophysiological concern with the patient. A nursing diagnosis is the physical manifestations of that disease process that need to be addressed.
That are kind of more currently affecting the patient. Yeah. So, and those can change throughout their care. If you address the pain and it's at a manageable state right now, that's not an appropriate nursing diagnosis for that patient anymore.
And there's they're called NANDAs, and they kind of publish new ones or keep the same ones every year.
There's books. Textbooks.
It's called the NANDA Handbook.
Yeah, that is it.
The NANDA Handbook.
They're up here.
I don't know if they've released the 2024 one yet, but they had one from last year. So another one for a liver patient. For those of you that know or don't know, I'll just give you like a little crash course on the liver.
Sure.
Liver does a lot of things. A lot of things. It helps metabolize things. It helps with your blood clotting. It also helps with fluid regulation with your portal vein. So, for example, somebody with liver cirrhosis may not be able to metabolize or get rid of this product called ammonia. And the physical manifestations of that is something called hepatic encephalopathy, which causes an altered mental status. Which causes acute confusion, delirium, and things like that. So your nursing diagnosis might be acute confusion. That's not the medical diagnosis of cirrhosis or hepatic encephalopathy, but that is the one of the main physical manifestations of that would be acute confusion. Or, for example, it also your liver also helps regulate your fluid volume balance based on like the pressure in your blood vessels, et cetera, et cetera, et cetera. I'm giving a very dumbed down explanation here because this is not a patho lesson. Okay, thanks, Simon. But as a result, the fluid balance in your body may become imbalanced. Hence the nursing diagnosis, fluid volume imbalance, and it either will be a fluid volume deficit or fluid volume excess. And that's an excess would be if you're really swollen because the fluid is various causes.
Liver, heart.
Yes, that is the physical manifestation of the medical diagnosis of. So it requires nursing diagnoses require a good combination of pathophys knowledge or pathophysiology knowledge, as well as just understanding of your patient condition. That's really you could know nothing about the pathophys behind cirrhosis, but if you're with your patient all day and you're watching their condition, you can still come up with a NANDA. You don't need to know that cirrhosis causes fluid volume imbalance if you notice that your patient is really swollen.
Yeah.
And it's really hypertensive, et cetera, et cetera, et cetera.
You also would need to know that directly from your patient because you're not just going to look up related nursing diagnoses and say, oh, this patient was confused, even though they were not confused. They were completely fine. Or, oh, this patient had excess, like fluid volume excess, and they were actually like super dehydrated. You need to know both. You need to know the pathophysiology, but you also need to know what's actually going on with your patient. And so with our care plans, that's kind of the goal. Two of the things that we talk about in our care plans is we put in basically a full SBAR. So we start the entire care plan off with the situation, their medical background, and then we go into a detailed assessment, a head-to-toe assessment. This is not the place to do a brief handoff report. This is like everything you possibly have found about this patient in their assessment. Then we move into like objective and subjective data, meaning it varies by clinical instructor, but
generally
it's the idea of what is reported in the chart objectively, the findings, and subjectively what the patient said or how they feel. Let's say pain's a bad one because that one's kind of
both. So actually, let's start with pain. Pain is both subjective and objective. Yeah. It's objective. The way that someone rates their pain, the way that someone rates their pain is subjective because nobody knows how they're feeling except for them.
Yeah.
So if someone says, oh, I'm experiencing 8 out of 10 pain, that's subjective. That's something that the patient is reporting to you. Objective data might be patient is grimacing or guarding.
Okay, that's good. Yeah.
Or patient
appears
blah, blah, blah. That's things that you are seeing with your own eyes.
Or that was reported.
Was reported. So subjective is things said directly from the patient.
Usually it's almost exclusively quotes. It'll be like patient states blah, blah, blah.
Yeah.
Patient family states blah, blah, blah.
Yeah. Stuff like lab values, vital signs, intake and output, recorded things,
even medications
that they're on, that would be objective. Because that's not something that you're like that can change based on your judgment. That is like the fact.
Objective.
The fact. The fact is that this patient got this medication, and the opinion is that this patient said, "Oh, I'm feeling this and this and this and this and this."
Yeah, which is also just as important.
Yeah,
it's getting an idea of how they feel about theirs. If you're putting them on a plan of care, like related to your nursing diagnoses, and they are not cooperating with it, which is also something we talk about in our table of nursing diagnoses, then they're never going to get discharged. If they don't agree with the plan of care, or they're not cooperating with it, or they're not participating in it, you're not going to get anywhere. And so that's kind of a key part too in analyzing the subjective data and analyzing how they're reacting to your interventions.
Yeah, and it also depends too, because sometimes patients are not always, they might be objectively symptomatic, but they're not feeling anything. So I've had patients that their heart rate was super high and they're telling me, I feel like I'm gonna have a heart attack, my heart is beating out of my chest. That's and it's true that it's always true what the patient feels, right? So it's true that they feel that way. But that's subjective just because that's what they're telling you.
Yeah.
The objective would be that their heart rate is super high. other times, you could have a patient that's heart rate is just as high, and they're like, oh, I feel perfectly fine. Like, there's nothing wrong.
Yeah.
And that's true.
And unless you talk to the patient.
Right, you would never know unless you talk to the patient.
Yeah.
So, yeah. Very important. Get to know your patient. Don't just look at the numbers. Look at the patient, not the chart. Like, look at the patient, not the vitals, because the patient will tell you more about their condition than any lab values might. The baseline is different for everybody.
Yeah, and there's a lot of like exam questions and stuff will go into that too. Like if you see like lab values don't immediately jump to the fact that it, like, or like vitals or anything, that's a big thing that gets tested on too. Like that concept of believing the patient and checking the patient first.
And with that being said, the same thing, you could have vital signs that appear completely quote unquote stable, but then your patient does not look or seem stable to you, and they're telling you that they're experiencing all of these things. You always believe the patient.
Okay, so our next, kind of going down the line of what a care plan is, we're talking about our objective, subjective, we have our assessment.
Those are tied together. The objective and subjective, you can only glean from your assessment.
Mm-hmm. And a lot of times instructors will want you to tie that back into your nursing diagnoses.
Mm-hmm.
So your assessment findings and your objective and subjective findings will be related to what your nursing diagnoses are. So you take these findings and you're like, this one, and this one relate to the fact that they have this nursing diagnosis, and here's what we're going to do about it, and here's how they reacted to it.
Yeah.
So then on top of that, you also have all of the relevant lab values, and then like obviously inferences as to how those are related to their care and all of that, and what you're going to do about it.
And relevant, and like we said before, like at the very beginning of this with SBAR, relevant does not always mean abnormal.
Yeah.
You can have relevant lab values that are both normal and not normal.
Mm-hmm.
And that's, for example, I'm just using cirrhosis because we were talking about it.
Yeah, sure.
You have a patient with cirrhosis, but their like liver function panel comes back perfectly fine. That's important to include because if you were getting all the information about this patient and you notice they have a very big liver problem, you're going to wonder, okay, well, what are their liver values show?
Right, and if you're not listing that shows that you're not fully understanding the concept of how this patient's doing, what needs to be addressed, what needs to be monitored.
Yeah.
And that's not safe patient care. So you really want to make sure you're monitoring the right things, and that, I think that's something that's hard to grasp in the beginning and really as you're first starting as a nursing student, knowing what values are important, knowing what, especially if they're not abnormal, knowing what to look out for. But yeah, that comes with time. And also asking your nurse, if you're filling out your care plan and you're looking at these labs and something doesn't make sense to you, or something, and this is in the afternoon when your nurse has more time, maybe after their lunch when they've eaten a little bit and they feel a little bit more energized, then go ahead and ask your questions about labs, ask your questions about medications, question certain things. And sometimes, who knows, maybe you're finding something that is like a discrepancy.
Yeah.
You'd be surprised how often that can happen. You're part of the care team. You're responsible to some extent for making sure that this patient is receiving the best care, and you're really diving deep into what is happening, their entire chart. You're looking at everything, and so you might be finding things that no one else has found.
And if your nurse is unable to answer those questions too, utilize other resources. You have your clinical instructor that should be on the floor with you at all times. You can ask them.
Yeah.
Don't go on your phone. Don't look it up on your phone. That's like a huge faux pas. It's considered very disrespectful, but it's also just not best practice.
Yeah.
You should avoid being on your phone at any time when you're dealing with like patient data. So like if you're sitting at the nursing station, you should not be on your phone. Even if you're not on a patient's chart, you still shouldn't be on your phone unless you need to message your clinical instructor about something. Otherwise, don't do it.
Yeah, I agree.
But besides that side note, you have other resources. Usually, the hospital computers, at any hospital that I've been at, they have the patient chart, and then they'll have lab values, and they'll have a range for those values on the chart, and then they'll have like a little like hyperlink that you can click to bring you to a different website about what that means. And if you don't know, they have specific like hospital search engines like Lexicomp.
And like evidence-based
articles
within,
and sources,
or policies and all of that.
So that you can look on those search engines or within the hospital's like library of evidence-based practice, what those lab values mean. You can also find hospital policies.
Policies are huge. Yeah.
Utilize the resources at your disposal. Same for medications. They have medical dictionaries and also like medication dictionaries and like micromedex or like med books that you can look up the different types of medications that
online
you're giving.
digital,
Online.
Especially with like medication interactions and all
That's
of that.
a huge one.
Yeah.
There's a lot.
Yes.
Sorry guys, we know this is a lot and it seems like a lot and it will feel like a lot at the beginning, but you'll get there.
Yeah.
It'll definitely.
We're here.
We're here. We made it.
We were there. Now we're here.
And there's still so much that we don't know.
So much. Are you kidding? The second we go into like a new grad program, I feel like we're just gonna be like the newbies all over again. Like have no idea, you know. And obviously, at a different level, there is so much that we've learned, but there is still just so much more to learn. And I think that's, I mean, even as a professional nurse, there's so much
always
to learn, and things are going to keep changing. We were just talking about that in our leadership class, how the technology and the resources being used in the hospital are just constantly changing.
I feel like
you just have to be able to adapt to that.
Yeah, I feel like even with every rotation that we've had, something new has been implemented.
Oh yeah, every time
something new has been implemented. The big one was with the type of charting system that one of the hospitals we work at uses. There was a big change to it, and they added something called like we talk about the BRUIN being on paper, but they added a BRUIN to the digital charting, and that was a huge thing, and we had to get oriented on that.
There's so many mixed feelings about it.
A lot of mixed feelings. Another time, for a different rotation, like one of the first days that we were there, they were implementing a new policy about IV insertions and dating tubing. So there's always, like even as quickly as like every few weeks.
Like, it's like as soon as evidence-based information comes out and the hospital catches up to it, they have to make those changes in order to keep their patients as safe as possible.
Yeah, I think that's like the big thing, is that nursing is always changing because we're always finding out new ways to keep people safer.
Yeah.
And it's really important like to keep that in mind, that like safety is the goal. And as much as you'll see things happening very seemingly hectically, and you'll feel like there's a lot to do and there's a lot you need to do in a certain amount of time, always prioritize safety over speed.
Yeah.
Always. Like, you don't have your license yet, but you need to act like you do in terms of like,
and you're working under someone's license.
Yes.
You have to respect that.
It's so much like, and I know the nurses that I've worked with feel the same way, as your patients also feel this way. It's always better to take more time to do something if it means it's going to happen safer. You really don't want to rush through something because you're worried about the time that something like will take. And again, also, just like we were saying before, like about volunteering for opportunities, if you're asked to do something you don't know how to do, but you're qualified to do it, that's when you, like we were saying before, you say, oh, I don't know, but I would love to learn how. But there are some times that you are asked to do something that it is not safe for you to do.
Oh yeah.
And you also have to advocate for yourself and say no.
And whether it's nurses asking you to do something because they're busy, or someone, a lot of times in those situations I've found that it's people who aren't nurses, like other people in the hospital that are asking you as a nursing student to do something, might be thinking that you're a nurse or thinking that you're someone else, whether it's a patient, a family, someone that works at the hospital, and you have to have the knowledge of the limitations of your care, and also the ability to redirect that and not just do it just because you feel awkward and you want to, you have to put your foot down and say, obviously in a respectful way, like, oh, I would love to do that for you, but that's out of the, that's not something I'm trained to do yet, so let me go get someone else to help you, or let me stay with you and call someone out, if it's a more emergent situation. Doing as much as you can within the limitations, but making sure you're not going beyond that, because that can have serious, serious consequences.
Yes, I would absolutely cannot emphasize that enough. Everything is about balance, and ultimately it's like the balance towards patient safety. So you want to, yes, you want to like take any opportunities that you can get, but again, like Lisa was saying, within the scope of your practice. Never, ever, 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 ever accept a task that is not, like, that you do not feel safe or comfortable doing. Whether that's someone asks you to do something and the way they're asking you to do it is against what you know to be or what you think to be hospital policy. You can always check. If a nurse or a physician or a care partner or anyone is asking you to do something that you don't feel comfortable doing it the way that they've asked you, you can verbalize that respectfully. You can ask if you can check hospital policy first to make sure you're doing it correctly.
It's for your safety. It's for your patient's safety.
And it's for your nurse's safety too. You don't ever want to accept a task just for the sake of doing a task.
Right. And with that also, I think that it requires some level of proactiveness. Let's say like you're being asked to, or you ask your nurse to administer the patient's medication with them. If it's your first time doing it that shift with this nurse, you've never been with this nurse before, you need to make sure that they know that they can't just walk out of the room and let you do all of the medications. They have to be there, and they're in charge of monitoring you, making sure that you're doing it the right way. So even if you seem confident enough to be able to do that yourself, that's out of your scope to be able to do that in a room by yourself.
Yeah.
So they have to stay there and watch you. And if they're not there, if they leave the room, you can't just continue doing what you're doing, because both of you are liable in that situation.
Yeah, I've had times like where that's happened, where I've been getting ready to administer either an IV medication or even oral medication, and something happened. One of the other patients needed help, and my nurse had to run out of the room to handle the situation, and it's just me and the patient and the medication. I can't finish giving that medication. No. Usually what I'll do in that situation is I'll like stick my head out, and if there's a nurse sitting at the computer not doing anything, or if I see my instructor, I'll ask them if they can come supervise me to administer the rest of the medication, or you have to wait.
Right. And it'll feel uncomfortable, and that's just the way it's going to be. The patient might complain, who knows, but that's the right thing to do, and that's the right thing to do, and that's the safest thing to do.
Yeah.
And so you have no other choice, Yeah.
It's you have to advocate for yourself, but you also have to advocate for the safety of your patient.
Definitely.
And sometimes patients, again, you have to keep in mind, like when you're in the hospital, the last place that these patients want to be is in the hospital. And so sometimes they'll ask you for things because they don't know the hospital policy, and they're in pain, and they're not feeling well, and they want that to be fixed immediately because anybody would. And they'll ask you for something that's not within your scope or that you can't do, and you also have to be comfortable being honest with them. It's so important for you to be honest with your patients, even if it's not the answer that they're hoping for.
Yeah.
If a patient asks you for something that's not within your scope, you have to explain that to them. If a patient asks you, oh, can you ask the nurse to give me this medication, but they just had that medication an hour ago, you have to be honest with them. And that's why it's important to know your medication administration.
Right, because let's say if you're saying like, oh yeah, I'll get that sorted for you right away, then you're giving them false hope about receiving that medication too.
Always be honest. If you don't know the answer, like I know this both from the nursing standpoint, a family member of somebody in the hospital standpoint, and as a patient myself, they will appreciate your honesty about not knowing something more than you being like, oh, of course, like, I'll get that for you right away. Or, like, if a patient asks you for water, and you know that you have something else, like, very important to do, don't say, oh, I'll get that for you right now, if you know you're not going to be able to do that.
Yeah.
You say, okay, I have to go give this, and once I'm done with that, I will be back.
And nurses say that all the time. That's completely acceptable to say.
Don't lie. Yeah. Don't lie to your patients. Even if it's like
They're
a little...
regular people.
Even, again, emphasizing that these are real people.
Yeah.
Even if it's like a little white lie, don't. Honesty
it's unprofessional.
and it's unsafe.
Yeah.
Again, all of this is about safety, and honesty is the only safe practice. Same with, don't tell a patient, oh, this medication is going to make you feel better. Oh, this is going to help you do this. Oh, it's going to be okay. You just say, this medication should help with this and this and this and this, and if it doesn't, we'll let us know and we'll try something else.
Yeah.
Or, oh, don't say like, oh, it's going to be okay, it's going to be okay. You don't know if it's going to be okay.
Right.
Don't lie to your, and they, like, again, these are real people. Like, they know, if they've been in the hospital for a while, they know that something is not going to make them feel better or that something will make them feel better. And if they're just in the hospital for a few days, like, don't tell them, oh, you're going to be leaving very soon. Like, I think you're going home tomorrow. That's like probably, I've seen that happen a lot of times. And not on purpose, never intentionally.
Yeah.
You also don't want to, and this ties into this, you don't want to give your patient information about their care without verifying with your nurse or physician first. So you don't want to tell your patient, like, if you overhear or if your nurse says, oh, I think that the patient is going for a procedure today, you don't tell your patient that until you know that they're going for that procedure today. You don't say, oh, I think you're getting this today, and then later they're like, I thought I was getting this today. Right. And you're like, oh, no, I didn't say you were. I just said I thought you were. Like, you don't.
Yeah. Just avoid it altogether.
Just avoid it, yeah.
Yeah, that's a great point. That's a really good point. So, our little advocacy spiel. Circling back to care plans to finish this off.
Sorry.
No, it's fine. We're planning it. The reason why we didn't want to dive too deep into that is because we're hopefully doing an episode in the near future, whether the next one or the one after that, about advocacy from a patient standpoint, as well as, like, we can go a little bit deeper into the nurse standpoint, even though I feel like we've done a good amount of talking about that here. But especially the idea for the next episode was advocating for yourself as a patient and speaking up in a respectful way to medical professionals and making sure that your needs are being heard within that 15-minute like outpatient interaction or within the hospital setting.
Yeah, and this won't be like just for future nurses or current nurses. This is going to be for anybody, teaching anybody how to advocate for themselves in any healthcare environment. I think we think that's really important. Yeah.
So that's a little sneak peek of what's coming up.
But back to care plans.
Back to care plans. We were talking about, let's see, we said medications and labs. And so then, so we were saying a little bit earlier that we talk about the pathophysiology of the disease. And so within our care plans, we kind of dive deep into one or two aspects of the pathophysiology of the main disease that patient is experiencing, or the main condition that they're going through, the reason they're in the hospital, circling back to the beginning of that SBAR, really getting a deeper understanding of, with this specific patient, what their symptoms are and why those symptoms are that way, and also in general, what that disease means for this patient, maybe what could be coming up for them with the progression of this disease. Just really having an understanding of what that disease means, especially if, let's say, this is a patient that just got diagnosed with this. They're going to have these questions. You're going to have to know how this disease progresses, what it means, how it will affect their day-to-day life. And that's the idea with pathophys, is that you're really understanding the disease process. Okay, so pathophys, we have our objective, subjective, SBAR. Andas?
Yeah.
Is our last point, right?
Yeah, you have to know, like, okay, so everything that we've said so far about the components of a care plan, like we said before, all culminates into your NANDAs.
Your nursing diagnoses.
Your nursing diagnoses.
NANDAs stand for? So, NANDAs, or nursing diagnoses, terms are interchangeable. NANDA, what does it stand for?
It formerly, I think it was like the North America Nursing Diagnosis Association.
That's the best thing we could find on the
internet.
Sorry.
We'll have the actual.
Are we gonna find anything else?
I don't know.
Okay, well,
that's okay.
I'll take a look. NANDA. Yeah. So we talked about a little bit the idea of what a nursing diagnosis is, and so with the table on our care plan, we will usually talk about 3 to 5 nursing diagnoses, and then it'll be like, let's say the nursing diagnosis is acute pain related to something, and then as evidenced by the actual objective and subjective data that we observed in the clinical setting that we listed above. And then we do another one, like, let's say, we keep using the same ones as examples. Let's say there's also risk for.
Risk for NANDAs, and that is something that they don't have yet, but they're at risk for it. You can't use a risk for NANDA if someone already has, like, evidence supporting that they are experiencing whatever. So, to put that in simpler terms, if your patient was at risk for bleeding, okay, that means that maybe their lab values show that their clotting time is very long, for like their clotting factors. Maybe they have either problems with their liver, or they have problems with perfusion, or with their circulating volume, or whatever the condition is. Maybe they have a low platelet count. This patient is at risk for bleeding.
Yeah.
Now, if this patient is at risk for bleeding and their hematocrit levels is low, their hemoglobin levels are low, they have a huge bruise, that patient's no longer at risk for bleeding. They bleeding. Are bleeding.
And
they are actively bleeding, and that is not a nursing diagnosis, because that is a physical, like that is an official diagnosis that somebody is bleeding. That surpasses the nursing diagnosis, which it's kind of, I know before we said it's like the physical manifestations, but it's a little bit more than that. It's more of like a clinical judgment.
Yeah.
And bleeding is not a nursing diagnosis. Risk for bleeding is. If that kind of explains the difference between a risk for and then an actual nursing diagnosis.
Yes, because also with the physical manifestations, there's also a lot of psychological NANDAs, and so that'll be we almost always have to include at least one or two psychological ones.
Yeah.
So that could be anything from like anxiety, and with that it can be more diagnostic.
It could be like ineffective coping.
Yeah.
You could have like impaired body image, knowledge deficit, and stuff like that. So for the example specifically for anxiety, if a patient has an official medical diagnosis of anxiety, you cannot use that as a nursing diagnosis. Yeah. Because remember, a nursing diagnosis is different than a medical diagnosis.
It's the acute symptom that they're feeling.
Yes, and so anxiety as a nursing diagnosis would be, for example, you have a patient on palliative care, they're talking a lot about their condition, they're crying a lot,
they're not coping well with it.
They're not coping well, they seem very anxious. That would be your nursing diagnosis, because they don't have that as a mental illness. That is a symptom of their physical condition, is anxiety. So that's kind of where, sometimes that's where the line draws. Like, for the same reason that if you have a patient that has medically been diagnosed with chronic pain, you can't use
acute pain
or chronic pain or any type of pain NANDA, because that is their actual official medical diagnosis. That is no longer just a symptom, if that makes sense.
Definitely. No, that's a good point. And so then after that we go into the goals for this patient. It's like goals and objectives, and those have to be SMART goals, meaning they're specific, measurable, attainable, realistic, and time-oriented, timely. So it could be something like, this patient, let's say that they are having trouble ambulating, they're having trouble walking around. So you could say, this patient will walk around the unit once with assistance by the end of the shift.
Yeah, so these are also things that you'll see reflected in your actual clinical as goals for you. In your SBAR, remember R stands for recommendation. This is usually when the handoff nurse will explain, so yesterday I got the patient was not able to walk, so I'm hoping that today you can get the patient up and walking a little bit.
Or to go take a bath. Eat all of their food, or
so you're
accept this medication.
So you want to be pulling your like objectives or goals for this patient, which are actually two different things. The goal and the objective is different, which we'll get into as well. You want to pull them from your actual patient if you can. Yeah. Especially if you're there for a 12-hour shift. I know sometimes you're only there for 6 hours, sometimes you're there for 10 hours, sometimes you're there for 8 hours. But if you're there for the whole day, that also shows that you really know your patient. And you don't want the difference between a goal and an objective is a goal is more broad, right? Or is it the other way around?
Goals are more broad, objectives are specific.
Yeah, so objectives are the SMART objectives and the goals are broad. So for example, like Lisa was saying, you have a patient on bed rest. They cannot ambulate. They have weakness in their lower extremities. Your goal would be that, like, what you would love to happen is that this patient is able to walk with minimal assistance.
Ideally, like, this is like by the time they're discharged or by the time they're better, like, this would eliminate this nursing diagnosis.
Yes.
If this goal was met.
Now, that is not always realistic.
It's not smart.
It's not a smart goal. Yes, it's not a smart objective. The objective would be, what do you want in the short term, most immediately to happen to help advance to that goal?
Mm-hmm.
Which would be what Lisa is saying, is that maybe they will get up for a total, I've used an objective where I was like, this patient will ambulate for a total of 20 minutes throughout the entire 12-hour shift. So that includes, they will get up and go to the bathroom once per shift. They will stand up to
or do stretches in bed,
in bed or stuff like that, because that is specific, measurable, achievable, realistic, and timely.
Nice.
So it has it has a time period that the goal or the objective should be accomplished by.
Yeah.
It is specific to the patient, so that's also important. You don't want to come up with an objective that is general for that. Like, that's what Lisa made a really good point earlier when she was saying that not every nursing diagnosis is applicable to your patient that may be applicable to the overall diagnosis.
Yeah.
The same is for objectives. So one objective for a patient with that condition might be good versus but you have to tailor it to your specific patient. If your patient is not on any, let's say your objective would be that this patient takes X, Y, and Z medication every 6 to 8 hours with this dosage. If your patient's not on those medications, don't have that as your objective.
Right.
It's not specific to your patient.
Right. And you want things that were actually, ideally with nursing diagnoses, they're things that you were able to observe within your shift, so that, because then the next steps are interventions related to those objectives, evaluations, interventions.
And then evaluations or reflection.
Yeah, but what's the one, like the evidence-based one?
Rationale,
thank you. So interventions, the rationale for those interventions, and then an evaluation for the success or not success, whether those failure,
whether those interventions were successful or unsuccessful, and then whether or not the interventions may have been successful, but they may not have been successful to achieving the objective. So there's a lot of critical thinking involved, and overall I think care plans, although they might seem tedious, they really do help your clinical judgment in the hospital setting.
Right, because you begin to think in the care plan-y way.
Sure.
You're thinking of goals for your patient to meet. You're thinking of what a realistic way to achieve those is. You're thinking of how they actually met those goals.
Correct.
And it also helps you with your handoff report to make sure that you're giving advice. When you start thinking in this way, it really creates better care for your patient.
Yeah,
at the end
absolutely.
Of the day. I don't know.
And this may seem like a lot, and we might be throwing a lot of words and explanations at you. We cannot, unfortunately,
most likely
attach an example of our care plan templates that our school gives us.
We obviously can't give you our actual care plans.
And we cannot give you our actual
information on them.
Because of HIPAA. Yeah.
But even the templates, I don't think we'd be able to give that. But regardless, it probably wouldn't help that much anyway, because each school is going to be so different. But I think you can kind of picture the idea of what information is important to gather from your patient, what that information would actually look like, how that's even relevant to your patient's care.
Yeah, and a lot of people, another tidbit about care plans tying into clinical, this might seem like it's not true, but assessment is a very big part of your care plan, because it's how you determine your nursing diagnosis and the plan of care. You will know, and a lot of people as a result will sit at the computer a lot when it's care plan time to get all of the necessary data from their patient's chart. You will learn so much more by actually interacting with your patient.
Even just talking to them. Not even doing an assessment, just talking to them about their experience.
Then you will, from the patient chart. Not to say that it's not important to be familiar with the chart, because of course it is. Yeah. But you don't want to be, we said before, the worst thing that you can do is sit at the computer all day. And there are so many other ways that you can get data for your care plan, for your clinical assignments, just by being in the patient's room.
Yeah. And a lot of times I've found that many things in the patient's chart are either not up to date or completely wrong. like correlating to what the patient is saying, like whether that's like simple things like family history or like even their actual experiences, their medical history, it could be things that are pretty relevant to the care. And if you write that down in your care plan and you're coming up with these goals, those might not be the most beneficial goals for this patient if you don't know what their actual scenario, their actual experience is.
Yeah, absolutely. And I think sometimes those discrepancies on the chart are either because someone may have misheard the patient, or they heard it in handoff and so they didn't ask the patient about it. So again, know the patient, not the data. Know your patient, because your patient, again, is a real life person. This is a real person that you are caring for. They're going to know how their body feels. They're going to know some of their history, probably more than the chart will. And that's unless, of course, maybe this patient has problems with their memory, or is experiencing like altered mental status or delirium or something like that.
Right.
But still, even in those cases, you will not be able to have a holistic image of your patient unless you spend time with them. And I feel like that's the thing that most people are scared of.
Even like especially in those cases, because those are the situations, or if there's like a language barrier with the patient, those are the situations where those patients are not receiving that level of care. Whether that's intentional or not, they're not having people sit with them and talk to them and really doing a thorough assessment, because they're kind of they're not receiving the same level of care as a patient that is fully verbal or speaks fluent English.
Because they're not as well, they don't have all of the tools to advocate for themselves, and even if they do have all of those tools, they may not be like received by the staff for whatever reason, again, whether that's intentionally or unintentionally. And most of the time it's of course unintentional, but it's important, like, again, to not, it's very easy when you have a lot of patients and when you had clinical for a few times, and you're busy and you have a lot going on, to like not take that extra time. But one unique perspective I feel like that we have as students, because we're newer to this and we haven't been in the hospital for years and we're still learning, we have that advantage where, like, I'm trying to figure out how to phrase this, where like we are seeing more of like the individual patients, if that makes sense. Like we are wanting and able to spend that, like use that to your advantage. Sometimes we have the time. Sometimes nurses don't. If they have 4 patients,
most of the time they don't,
and they have to like do all of they can to just keep the patient stable, and care for their needs, and you get assigned maybe 1 or 2 patients, and your nurse does not need help with the other patients. Use the extra time that you have instead of sitting at the computer.
You can make a real difference. Like, you have a unique advantage with your situation that you won't have at any other point in your career, where you have the time and you have the resources to be able to create that change in your patient's plan of care.
And I think the reason that like I keep emphasizing so strongly that like these are real people, like with real feelings and real everything, is not because like you would think, well, of course they're real people. But the implications of that, it can be in the hustle and bustle of everything. Sometimes people will forget. So it's really important that you're advocating for, again, tying everything back to advocacy. They're all tied together, all of it. Advocating for yourself is so important, in terms of maintaining patient safety. Your care plan cannot be a successful or well thought out care plan unless you really get to know your patient.
Which includes advocating
advocating for your patient.
Yeah, I think that's a good note to end on.
Overall, like to summarize, be confident. You know more than you think you do, and if you don't, that's fine. Just ask.
Okay, just ask.
Just ask. Don't be afraid to ask. Know your limits. Know your boundaries.
Know safety protocols.
And again, like the most important thing, if you don't know, ask.
You have to
look for the answer.
You have to be prepared going into this. Whether or not you're prepared beforehand, be prepared. Like, prepare yourself within that situation before you
do anything.
Yeah.
And it's not embarrassing to have to look for something. Like, either ask or look. It's always safe. Again, always safety is like the utmost importance.
Definitely.
Just be safe. It's not like dumb, it's not embarrassing, it's safe.
Mm-hmm. Yeah. Safety.
Okay. Yeah, if you guys have any more questions, I feel like we hit a lot of stuff, but that was also, again, that was a lot of stuff that we kind of threw out there. You got this.
Yeah.
If you have any more questions that you would like us to answer,
related to this, not related to this,
anything really, just
shoot it down below.
Drop it down below. And maybe next week or in the upcoming future, again, we'll talk about how to advocate for yourself as a patient.
Yeah.
Which, if you're a healthcare professional, if you're a future healthcare professional, this can also help you advocate for your patients better. And if you're not, and even if you are, this will help you with yourself. So look forward to that in the future, amongst many other exciting things. And also,
nursing related, not nursing related.
There's anything you want us to talk about too?
Always down there. Also, I feel like I never mentioned this, but I do have my email, I have my Instagram, and all of that linked onto my YouTube. If it's something that you don't feel like necessarily mentioning in the comments in front of
people,
the 15 people that see this, you could also send it to me there privately.
Yeah.
We can have a conversation. If you don't want me to mention it in a video, we can just chat on there. That's all.
That's it.
Do you want to do the...
Yeah, okay. And with that,
that was Clinical Crash Course
Week 2 with
BRUIN
BANTER.
All right.
That was really good, Lucy.